yeah, we'll start and then we can, if anybody comes, they'll jump in. So this week, we're going to do it a little different. There's so many different fracture patterns, dislocations. I really just wanted to review some of the really key fractures, dislocations, show you guys the x-rays, kind of initially discuss management, splinting, things like that. And I didn't do the questions because next week we will have... Oh, here, sorry. I'm gonna see. Do you mind muting if you're...
Mình chỉ có chụp cái tiện đây chưa? Bên này không có mời.
Do you mind muting?
Cái tờ tiền mê đấy không?
Oh, there we go. Anyways, so this week we'll just kind of talk about it. I didn't do questions. Next week they're gonna try to do some more review splinting, and do some stuff on the ground that's a little bit easier. So thought we'd be okay foregoing questions this week so we could focus on more and not feel so rushed and or go over, because I know you guys are extremely busy. So just kind of diving in, the general approach to any orthopedic injury is really the same. So somebody comes to your ER and they've had an orthopedic injury. So first and foremost, you want to perform a thorough exam, like a trauma assessment, and make sure you're not missing another injury, specifically a head or neck injury. A lot of times an extremity injury can be very distracting because it's painful, the patient sees it, and this can lead to you missing other injuries, so a head injury or a neck or back injury. So on all these patients, make sure that you're really thoroughly examining them. Make sure you're examining the joints above and below. You always want to undress these patients. If it's an isolated injury, just make sure you're undressing that area. The other thing that I see get overlooked a lot is like newer, physicians, or sometimes if people are busy, they won't take the splints off before they get an x-ray, or all this stuff gets missed. Somebody's outside the hospital or EMS or family member puts a splint on and then it doesn't get unwrapped. Well, the problem with that is, what if you unwrap it and you see a big open wound and you now know you have an open fracture? That totally changes your management, what you're going to do with this patient, how quickly you get them assessed and evaluated. So when you see the patient for the first time, make sure you take off any bandages, wraps, splints that they have in place, because you need to know what's going on. Look at the skin. It's going to be painful, but if the patient, say they're holding their arm splinted like this, I'll try to show you guys, make sure you look on the other side. Really assess the skin. Look for any tinting of the skin, any areas of discoloration, because those can be signs of an impending open fracture. If that skin is tinting, it can cause some damage to the skin and the vessels around the skin, and then it doesn't heal. And it can cause a pressure ulcer. All those things can be indicators for performing surgery for the orthopedic surgeon. So make sure you're doing good exams. On all these patients, you need to make sure you're palpating, or as Dr. Dye was saying before we started, using an ultrasound to assess pulses. So look at your pulses above and below the injury. Look at capillary refill, make sure there's good color to the skin, and then assess for sensation. Make sure that there's no sign of neurological injury or a vessel or a nerve injury, and that's checking the sensation. It's good to review anatomy when you have fractures, know where certain nerves are innervating, so that if you do indicate or see where there's a diminished sensation, you can have okay, maybe we have the radial nerve is affected or the ulnar nerve. So just knowing that anatomy is pretty important and can really help you. And then with these patients, don't just do it once and say, okay, we're fine, especially some of these injuries that have a high likelihood. I often will do a repeat check of their neurovascular status after x-raying, because when you're getting x-rays, they're moving their extremity. That can change how the fracture is, and things can change. And so you always want to be reassessing, having your nurses reassess if you're, extremely busy. And then after any reductions or splinting, make sure you're reassessing. Be on the lookout for compartment syndrome, and we'll talk about that with more length next week. But with compartment syndrome, the first sign is usually pain, so extreme pain, but you can also get pallor, so the skin or the area of the fracture looks really pale. There's paresthesia or numbness, paresis, paralysis, and then pulselessness, so no pulses, and then poikilothermia, which is an inability to sense temperature. So those can all be signs of compartment syndrome. If you're suspicious of compartment syndrome, we'll talk about this next week. That's an indication to get your orthopedic surgeon on board early and or check the pressures in the compartments. You can elevate the extremity. That can help decrease swelling and minimize your risk for compartment syndrome and make splinting easier and decrease pain as well. These patients will need pain control. It's going to make your life easier. It's going to make your x-ray better. So if you can, try to get them pain medicine before you get x-rays, because that allows your x-ray technician to get a better x-ray because they can move the extremity. X-ray is typically a great diagnostic modality in this. You can, if for any reason you can't get a quick x-ray, which you should be able to, you can use ultrasound. And then in some cases, you will need to get a CAT scan for more detail of the fracture, or if you're missing an initial fracture, but you're highly suspicious, or if your orthopedic surgeon requests it. So when do we reduce fractures? It's good to know, why are we reducing it? When are we reducing it? Anytime fracture edges are displaced or there's an obvious deformity on an external exam, that fracture is going to need to be manipulated or reduced. And for sure, anytime there's neurovascular compromise, you're going to need a reduction. And then anytime there's concern for compartment syndrome secondary to that fracture being displaced, it's likely going to need to be reduced. If there's neurovascular compromise or concern for compartment syndrome, you want to reduce sooner rather than later. So in some cases, if you're highly suspicious and there's neurovascular compromise, you don't even need to wait for an x-ray. You can just look at the extremity and reduce so that it looks in more proper alignment. The benefits of reducing a fracture or dislocation are numerous. It usually does improve pain for the patient. That's because there's nerve endings on the ends of bones. So when they're fractured and then they rub together, it's extremely painful. It can remove any tension from the skin. It can reduce swelling. It will aid in the healing, helps retain function of the extremity, and that's especially if you get a good reduction solidly in place. And it will speed your healing and reduce any need for surgical intervention. So, older people, poor surgical candidates, it's really important in these people to get a good reduction and make sure it's good and it's splinted well, because they're not great surgical candidates. So if you can, in that initial evaluation and treatment, do a good job and reduce their need for surgery, you can significantly increase their long-term morbidity and mortality, because fractures can be life-changing for an elder person. So it's really important actually to get a good reduction, be confident in your reduction, and do it well. If you're doing a reduction, you're usually going to have more success if you have your patient's pain controlled or managed. So you can do this a number of ways. Some people will use you can use a general pain medicine, so opioids, morphine, fentanyl, things like that. You can also, with local anesthetics, so you can do what's called the hematoma block. So you can inject lidocaine or bupivacaine into the fracture itself. And you can do joint blocks. You can also do nerve blocks if you become good at that. And for certain fractures, and I have some videos pasted in here for you guys to look at later when I send out the PowerPoints. You can try those things. This is a good place for conscious sedation if you have staffing and ability. So if you can do a sedation, a lot of times you'll get a better reduction with sedation. So, this isn't really the block where I'm going to talk about the sedation of it. I preferably will, for orthopedic sedations, I like to use a combination of ketamine and propofol. Those are my usual two go-tos, depending on the fracture, dislocation, how long splinting is going to take. And, in some cases, it's just really better to do it for the patient and so that you get a good reduction. So the general maneuver of a reduction, you're going to usually need two people. So you're going to have to get an assistant with this, and that's one to help stabilize, another to pull. Sometimes you're going to need more than that, somebody to help you navigate with the C-arm, another person to help with sedation. So these do usually require a fair amount of staffing to do right. with the fracture reduction, for the most part, you're going to slightly accentuate the fracture pattern and then pull traction. And for certain fractures, I have some images put in and you'll see those. And then, always good to look and refresh and have your own techniques for things. The goal is always to attempt minimal reduction. So especially like in kids or things that cross joint lines or growth plates, it's better just to pull once. So not like baby movements. You're doing one good solid pull, because the more times you attempt a reduction, the more like slight pulling, the more likely you are to cause other damage and or like small micro fractures. So try to just do it once. Make sure when you start these, you have everything you're going to need, all your splinting materials, slings if you're going to need it for a dislocation, splints, everything ready in place so that you minimize your time, especially if your patient's sedated, that you need sedation, your resources, you being in the room, and you're going to have more success that way. Once it's been splinted, reduced, it is always a good idea to get a repeat x-ray to make sure you're in proper position, everything's realigned. And then if you can use a portable x-ray, which I'm not sure if you guys have that ability, but if you do, they're usually great and can sometimes borrow them from the OR. So kind of diving in, we'll talk about some of the most common fractures that we see. This is not an inclusive list. There's others. I'm sure you guys will think of others, but it's an hour for an entire ortho. So hand, we're going to start with hand. So here, and let me say throughout any of these fractures or anything, you guys can speak up if you have questions, or you can write something in the chat and I'll try to keep an eye on it, because I know this is a lot of material. I also know you guys see a lot of ortho, but this is meant to be kind of a review. So one of the most common fractures we'll see that's, clinically significant is a boxer's fracture. They call it a boxer's fracture because it's usually sustained by somebody punching a wall or punching another person, and the pressure on the hand here will cause a fracture, usually the fifth or fourth metacarpal, as we see here. These are often displaced because of the nature of it and the way the bone is. They're small bones, so when they fracture, they often get displaced, as you see here. If the fracture is not displaced, it's just like in simple alignment, then you don't need to reduce it. But as in like this case, you would need to reduce this. The reason being that it will kind of inhibit a person's ability to like move their hand if you don't reduce it. The reduction for these is kind of depicted below. So you'll have the patient kind of bend their hand down, and then you'll grab here, put pressure on I liked this picture, but put pressure on the metacarpal while pulling and pushing that finger upwards, and that usually pops the finger into place. These don't often need a ton of force because it's a hand, but sometimes if the person's hand is much bigger than yours, there are times when you would need somebody to put the pressure on the metacarpal, and you could just focus on pulling upwards or pushing upward. And you can usually feel these ones go back into place. Once it's been reduced, you're going to put a splint on, and this is an ulnar gutter. So the ulnar gutter is going to be on the side. That's why they call it an ulnar gutter, because it's kind of shaped like a gutter, or the what you would put on the side of a house, and it kind of curls to the ulna. So talk about that next week with the residents that are coming and practicing some splinting. So ulnar gutter for this one, boxer's fracture. These don't often need surgery. On rare occasion, they do, depending on the patient's job as well, if it's really important to them, or they would maybe get a pin in there, but most of the times these will heal on their own pretty well. So next, very significant hand fracture would be a scaphoid fracture. So you can see here in the picture, there's the scaphoid, and then there's the fracture. So there's that bone, and then that's the fracture pattern. The scaphoid, because of its location, it is kind of in an area where it doesn't get great blood flow. So often when these fracture, if they're not put in good alignment initially or splinted and the patient's moving around, they don't get blood flow to the fracture. When they're not getting blood flow to the fracture, it doesn't get the material needed to rebuild that matrix, and it doesn't heal. if this bone doesn't heal, what happens is it really diminishes a person's ability to flatten their hand. So you can't like put your hand flat anymore. You couldn't like put it on a flat surface. And some people have continued or ongoing pain with any movement of the hand. And so it's really important to, if you identify these fractures, get them splinted, have them follow up with a hand surgeon, orthopedic surgeon for continued follow up. They will sometimes do surgery on these, put a pin in because of the risk of that non healing. The tricky thing with this fracture is that if you don't get a good view, there's a specific view you can get and ask them to get it a scaphoid view X-ray. But if you don't get a good view, sometimes X-ray can miss these. So if you have high suspicion and the area of pain is going to be right here. So snuff box. So the anatomical snuff box. So if you make a little thing like this with your hand and you get this little area here, it's really hard to see, but the snuff box, if there's pain in here and you're highly suspicious because somebody's fallen on their hand and they're having a lot of pain here, but the X-ray looks normal, you can go ahead and put them in a splint and have them get a repeat X-ray in 5 to 7 days. Or if they don't have good follow-up, you can just get a CAT scan of the hand. And it's not always overkill because these are, in somebody's hand, it's high liability if you miss it and not great for the patient. So you can kind of do those two things. You can splint them and have them repeat X-ray or get a CAT scan if the X-ray looks negative, but you're really suspicious because they have that tenderness here in the snuff box. The splinting for these, so these don't often need reduction. There's not a lot to reduce here. So you're not going to do a big reduction, but you're going to put them in a thumb spica. So the thumb spica goes over the thumb and then down to the wrist to prevent any movement of the thumb itself. So next is the forearm. So first, there's quite a few forearm fractures and their names and various patterns. If you know a couple, it's good you can understand the principles. So first one is a more minor fracture. It's called a green stick fracture, and it just raises because you will see these ones fairly often. It's called a green stick fracture, and for you guys this is like a weird language thing, but it's a green stick because in the US it can come from green sticks are like batons that police used to hold, and so if somebody's like a police was hitting them with those batons, the green sticks, and you hold your arm like this to protect yourself from being hit, the stick would hit right here and cause this fracture pattern. So that's how it gets its name. You can also think of it like a stick would bend if you tried to snap it. So this is going to be when just one side of the bone is fractured, as you can see here. So it kind of bends and then it's only fractured on one side. These are typically not displaced significantly and they won't need to be reduced. They heal fairly well on their own. And for the most part, based on where they are located, you can just put the patient in a sugar tongue splint. So again, the splints, you can always look them up, but you guys will talk about them with the residents next week. So a sugar tongue splint. And that's a splint that, comes up, wraps around the forearm. So next fracture, this is called a Colles fracture. This is one that we all probably see very frequently. This is a super common fracture, and it will occur when a person falls onto their hand, and an outstretched pattern can happen in anybody depending on the level of force. In elder people, barely a fall. In younger people, kids, adults, it can happen with any type of activity. So these are really common fracture. It is a Colles fracture is a distal fracture of the radius and ulna, as you see here. And these are very oftenly displaced. A lot of times these do involve the joint space, so they become intra-articular. So really important to take note if they are involving the joint, which this one, I don't know if it is. You'd have to get a different view. This is just a single view. But you can see they're often displaced. These will very often need to be reduced. Now, with elder patients, this is one where very, very critical to get a good reduction. Anybody that's younger, a good surgical candidate, they a lot of times will end up needing surgery for these because they can be unstable. But you can, if you get a really good reduction, like this is a great reduction. If you get a really good reduction, you can prevent surgery in a lot of cases. when you do a reduction of these, so you can do a hematoma block. A lot of times these ones will need sedation so that you can get a really good reduction of it. And because they're extremely painful and needs a pretty good amount of pulling and force to get it done. So once you can either do the hematoma block, sedate them, and then like we talked about, you're going to kind of accentuate the fracture pattern, pushing here, accentuating the fracture pattern, and then pulling and straightening that arm when you do the reduction. These will need splinted if you can. These are ones where it's good to use a really good splint put in place because they can be unstable, making sure that the reduction stays in place and then getting an x-ray. When they are discharged, you'd have them follow up with the surgeon. A lot of times they'll get a repeat x-ray in 1 to 2 weeks and see how the fracture is healing and then determine if that patient may need surgery or not. So this fracture, so the next two fractures, for us and like our board testing, we get tested on these a lot. So I do want to tell you, and like, it's good to know the names because you will see them come up. They're fractures that you see, and they're kind of distinct fracture patterns. So the first one is called a Montasia fracture. And this is when you have a displaced proximal ulna fracture. So this is the shaft of the ulna fractured. And you're going to have a dislocation of the radial head, as you see here. So the radial head should be sitting in here, and it's up here. These are more common in children. You can see this is a child. See, the growth plates are still open. So this is a pediatric x-ray. So this fracture, this is going to be displaced up here. These have a high likelihood or risk for an injury, of a vascular injury, because radial artery comes right through here. So you see this would pop up and maybe affect the vessel, also the nerve. And they can cause compartment syndrome because there's the fracture here plus the dislocation. So there's a lot of stress in this area, a lot of swelling. So you want to do thorough compartment checks, vascular checks on these ones. And they will present in adults. You can get them as an adult. The radial head's usually a little more in place for adults, so it happens less likely. You're more likely to get that Colles fracture if so patient falls. These will almost always require an orthopedic surgery consultation because the complexity of this. You can reduce it in the emergency department, so it's going to require kind of using counter traction here and then pulling the extremity this way while somebody puts pressure down on this area. Once it's been reduced, you get a repeat x-ray, put the patient in. You can use a sugar tongue. Some people for these will like to extend the splint up a little bit onto the upper arm to prevent any rotation of the forearm. And they will need surgery a lot of times after you do. But same thing, if it's in kids, sometimes they can get away with making them non-operative. So this next fracture pattern is called a Galeazzi fracture. And like I said, there's those two. We get tested on them a lot in our ER world and boards, and it's good to know these fracture patterns. So this one is a fracture of the distal radius. So fracture of the radius, there's the radial fracture, and then a distal radial ulnar joint dislocation. So this is the radial ulnar joint. So this is actually the ulna, but this one that's dislocated, and then it's dislocated here, but that's called the radial ulnar joint. But it is the ulna that's dislocated, the radius that's fractured, so opposite bones. This one is often associated with disruption of the interosseous membrane, and we'll talk about that with another fracture. But in any set of bones, like when you have two bones together, an interosseous membrane is between the bones, osseous is bone, so between the bones, membrane. So it's a connective tissue that basically connects the two bones to prevent them from coming apart or rotating about each other. So they kind of tie the two together, like cobweb them together with this fracture pattern that gets disrupted. If that's disrupted, you can risk fracture above, like in any area of the membrane, as well as the dislocation, like you can see there. These are usually very unstable. So that's the other thing, when you disrupt that membrane, it causes increased instability because it's not being held in place. So a lot of times these will need surgery. So the minute you reduce them, it'll just come back out because there's nothing holding it in place internally. But you can attempt a reduction, which you usually should in this case, and then place the patient in a splint. So next one, this is a classic elbow dislocation. So you see how this socket has come out here and dislocated. These are common. They can happen, fall on an outstretched hand. People that have had previous elbow dislocations are high risk for them occurring again. They can be associated with a nerve or vascular injury, again, because the vascular nerves run through here in that antecubital fossa here. If there's any concern for neurovascular compromise, you can see that it's obviously dislocated. You can perform the reduction prior to getting an x-ray or try to snap a quick x-ray. In elder people, these are often associated with a fracture, so it's not just a pure dislocation. You get a fracture dislocation. The fracture can occur on the head here of the humerus or within this olecranon. It doesn't change that you need to reduce it. It just changes that sometimes after the reduction and splinting and in follow-up, they may need surgery. These do tend to be unstable because it's held pretty tightly. This joint is held pretty tightly with ligaments. So if you have enough force to cause a dislocation, you often have disruption of the ligamentous structures. And so if the ligaments are disrupted that are holding that bone in place, then a lot of times it's really unstable. So make sure that after you perform your reduction, you place the patient in a splint. If you can, there's like a hinged elbow brace that you can get access to that we'll use sometimes, and that's usually what they put them in after surgery. If you don't have that, it's fine. You can do a splint where you're extending from up on the humerus down and around to prevent any rotational movement as well as flexion extension about the elbow there. The reduction for this I kind of have depicted here. There's a few different techniques. There's techniques where they'll have people, you can like hold their forearm, and really kind of great techniques you can look up. Depending on your size, you have to see what works for you. I'm a smaller person, and so I've kind of developed reductions that work for my size, especially when I'm working with patients that are much bigger than me, and then getting people's help. With this one, you do often need quite a bit of counter traction, so somebody pulling on the humerus, and then you are going to put pressure on the olecranon, and then somebody else is going to pull traction with fixation here. So these are actually a pretty fun reduction if you get the chance to do them, and you usually get a very, very loud audible click when it goes back into place. Next is the upper arm fracture, so a humerus fracture. This is also very common, probably when you guys see a lot. I feel like we see these all the time. So proximal humerus fracture, and you see the fracture pattern. They can be anywhere along this area. So these are very common in elder patients, especially elder females with osteoporosis, so in osteoporotic bones. This is an area that, because you don't put a lot of weight bearing into this area, because you remember, like, any weight bearing exercises help prevent osteoporosis, but there's not a lot of weight bearing, so the matrix in this area of the bone gets degraded with age, and so it's fairly weak. So if you fall on an outstretched hand, if you fall onto your elbow at all, you have risk for fracturing here. You do want to make sure that you don't have an associated shoulder dislocation when you see these fractures. So try to get as many views of that shoulder as you can, like a Y view. If there's still concern or a lot of concern, you can get a CAT scan to make sure it's not dislocated. These do not often need reduction. You can just use gravity to allow for a slow reduction. So you would place these patients in a sling where their arm would hang down low, and gravity would pull and it'll reduce on its own. You don't have to pull unless there is an associated dislocation of that shoulder. These are very rarely surgical because they do reduce fairly well on their own, and because a lot of times they are occurring in elder patients that are not great surgical candidates. So a lot of times orthopedic surgeons aren't, anxious to take those people to the OR. So you wouldn't do surgery. If it occurs in a younger person with high force or high trauma, or there's polytrauma, then sometimes they will put a plate in those. And these can be painful, so treat with pain medication. You can also do a block, like a hematoma block, to minimize in an older person how much sedation or how many narcotic medications you're giving them. So just remember that. So next and one, if you guys see, I love them. I love shoulder dislocations, and I like seeing patients with these. But so shoulder dislocations, also very common. It's a really complex joint because it moves in so many dimensions. So it really commonly comes out, and patients will have recurrent dislocations. A lot of ways you can get this out. Shoulder dislocations, 95% of shoulder dislocations are anterior. So this is a depiction of an anterior dislocation. To dislocate the shoulder posterior, you usually need a lot of force. So we think of that with like seizures. Somebody is having a seizure, you can get the bilateral shoulder dislocation, or in a shock injury where somebody's like jolted because they get electrocuted, and you will see those. Most of the time it's anterior. It is caused when the arm is excessively abducted, so out, and then externally rotated. Like I said, these are kind of longer videos, so I don't want to play them now just for sake of time. But when I send this out, you guys will have access. I put these as hyperlinks. So there's a ton of different reductions for shoulder techniques for shoulder. So everybody kind of has a preference for how they like to do them, and it's good to like have them and know a couple so that if one isn't working, you can try something else, and depending on the patient that you're working with. So I really highly recommend this when you're doing a shoulder reduction. So I personally, I don't like to sedate for shoulder reductions because I find if you get good, there's other ways to do it without, using the time and resources for doing a sedation. And some patients will request it, or if you attempt without sedation and it's not working, then you can go to sedation. If you don't want to do sedation, a great thing to do is an intra-articular injection. So, and then here again, there's a video of this, and you can use ultrasound. So you would use ultrasound to go into the joint space with a needle, inject into this area lidocaine and or bupivacaine or any other anti-anesthetic, and would go right into this area, inject, and I usually will inject like 10 to 15 cc's or milliliters of medication in here, and that gives really good. It will help with blocking that and pain control. In addition, I'd give like a narcotic pain medicine, and between the two, you can often get it without having to sedate the patient. Patients will usually know when it's reduced. One quick bedside test you can do is you have them take their shoulder and take their hand and then touch their other shoulder. Because you're not externally rotating at all, you're not at risk for having them re-dislocate their shoulder. So once you feel like it's in place, before you get an x-ray, you can have them go up and touch. If it's still dislocated at all, they won't be able to physically do this because their arm won't bend that way. But by doing this, you're not risking them re-dislocating their shoulder. So if you try to have them move all around, you might pop it right back out. But you can have them just go ahead and reach and touch their other shoulder. Once it's reduced, put it in a sling, and then get an x-ray. I would recommend, once you've done it, just in follow-up, then they don't always have to see a surgeon unless they've had recurrent dislocations, more likely a primary care doctor or a physical therapist, so they can gradually rebuild that muscle in there, especially the rotator cuff muscles that can sometimes get weak with these dislocations, to prevent it from recurring. So moving down to the lower extremities. So this is called a Lisfranc fracture. This is one important to know and can be easily missed, and can be missed by radiologists, can be missed by practitioners, and so good to be aware of this fracture. The Lisfranc joint is an articulation between the proximal first, second, and third metatarsals. So more in here, this is first and second, but it can also be in here with cuneiforms and the fourth, fifth metatarsals and the cuboid. So it's like this one here, this one, it's between, and then the cuboids here. So this is basically that joint space. They will often present with pain over the midfoot, so in here, and inability to bear weight. With these, you can also get plantar arch. So on the other side, the plantar arch ecchymosis, or called the Mondor sign. If you see that, you need to be highly suspicious of a Lisfranc injury, but it's not always there. These are often associated with polytrauma, so motor vehicle accidents. You'll see them, and they can get missed in NVCs because, like, say somebody has a neck or head injury or another extremity injury, you're not always looking at their feet, or they're not bearing weight in the trauma bay. So, make sure that you're doing a thorough exam, like we talked about, on all those patients, and then reassessing again and again to see if anything new comes up. If your x-ray is negative, but somebody has a ton of pain in this area, and you're like, hey, you know what, maybe they have a Lisfranc, you can get a weight-bearing x-ray. So you have them stand, because when they stand, it will widen this space. Or you can get a CAT scan of the area if they're unable to stand and bear weight, and that'll show to make sure there's no disruption of this area. If you miss it, it can cause long-term morbidity. You're going to have a lot of pain with anytime you lay this foot flat, and it can cause severe injuries. In the United States, there's actually a football player that had like a longly missed Lisfranc, and I think it pretty much ruined his career. So it can be really a debilitating injury. If you do diagnosis, you're going to immobilize with a short leg posterior splint, and that's to prevent any type of flexion extension about the heel or the midfoot itself. And then make sure they're non-weight bearing in order for that to heal. If they're with any of this injury, I would consult orthopedic surgery. A lot of times these will require surgery so that you can stabilize it, and then at least long-term follow-up to make sure that it's healing appropriately. So next fracture would be a calcaneal fracture, so heel fracture. These are most commonly occur secondary to a compression following a fall from height. So somebody falls, they land on their heels, and then they'll sustain a heel fracture. These are extremely painful. They take a ton of force in order to fracture that heel. If you see a heel fracture, you need to be thinking, are there other injuries from this fall? And the heel fracture can be so painful that it can allow you to miss other fractures because the patient is really focusing on their feet and how bad their foot hurts. Whereas when they fall, you can still get other injuries from axial load or fall from height. You can get knee injuries, hip injuries, and then spine fractures. So make sure you're doing thorough evaluations of the spines, hips, if that fracture is really bad. And a lot of times I just preemptively will scan the spines. If I see a calcaneal fracture, especially if there's a bilateral fracture, I will just go ahead and get CAT scans of the neck, thoracic, and lumbar spine to rule out fracture because they are just so commonly associated with this. As far as CT of the heel, they are indicated in a lot of cases because a plain film x-ray can miss fractures that involve the joint space here, like that are interarticular space. And then a lot of times surgeons will want the CAT scan so that they can plan surgery just to see where the fracture pattern is. And then a lot of times you're scanning other areas, so you can just go ahead and include the foot in this heel here. If get a CAT scan if the x-ray is not showing anything, but somebody's like unable to put any weight or they've had a fall from height, you can scan them to make sure you're not missing a fracture. So these will require a posterior splint and with a ton of padding because there's a lot of tension and pressure and they're not moving, they can get blisters and then the skin can slough off and be damaged here. This specific fracture is called a tongue type calcaneus fracture because it looks like a tongue. You can see like kind of a mouth. With this fracture, they will sometimes these are just open, or you can see there's tons of tinting. This fracture, it's hard to say without seeing the patient. It's either open or it's splinted. It's like tinting the skin, and that causes a lot of damage, injury to the skin itself. And then that damage would be injury. So this person would need surgery, and they usually need surgery pretty quickly to make sure they don't kill all the skin there. So ankle fractures, again, another one we see. There's ankle fractures, there's fracture dislocations, there's a single malleolus fracture, bimalleolar fracture, there's isolated fractures of the talus, so many fractures, and you see like time is flying with this. So I have here a picture of a trimalleolar fracture. So these are very common. Trimalleolar fracture is going to be where you have three malleolus, so the lateral, the medial, and then that posterior malleolus. So you can see there's all three. With the ankle, make sure you always want to get any fracture really at least two views so that you can see both views, see both sides. But this would be a trimalleolar fracture. Anytime more than one of the malleolus in this ankle joint are fractured, it's going to be considered an unstable fracture because this is called your talus, and your talus can move about in that area and be unstable. If you see this fracture, you need to be concerned for a syndesmotic injury. So the syndesmosis is this, it's the kind of like we talked about, but the interosseous membrane. So if you see this fracture, you can have disruption of that membrane, which can cause a fracture more proximal. So like a superior fibular fracture. So always go up. You can squeeze their calf, see if they have any pain above. And then a lot of times on trimalleolar fractures, you're not wrong either to just go ahead and get an x-ray of the tib, fib, and then the knee as well to make sure you're not missing an injury. If there's any concern for neurovascular compromise, so diminished pulses or sensation, go ahead and you can perform the reduction immediately as quick as possible. Or you could even, you don't even need to wait for x-ray. If it's a fracture dislocation of the ankle, sometimes they're really obvious. You can see externally. So if there's any concern for neurovascular compromise, you can go ahead with it or wait and just do it. The reduction for these is often to put the patient in, so you dorsiflex their heel or their foot, sorry. So dorsiflex their foot, have somebody pull counter traction, and then just accentuate the fracture pattern slightly, pull, and then pull out. Once you get a good reduction of this, you're going to want to put a splint on. So the splint is going to be a stirrup splint. So you're going to go up and around the foot as well as posterior. So two different splints where you put them together so that you cannot flex or extend the foot and you can't rotate it either. Most of the time, a trimalleolar fracture is going to end up needing surgery because it is so unstable, and then it takes a long time to heal. And so a patient would need to be non-weight bearing for a very long time, and it can really make it tough. So the benefit of surgery in these cases is usually better. These do tend to occur more often in younger people doing activities that fracture themselves so they can get surgery. So a lot of times these will end up needing surgery. Not always immediately. Sometimes it can wait, especially if there's a lot of swelling. Surgeons will like to wait. But make sure you're getting your orthopedic surgeons involved in these ones, either in follow-up or immediately. So lower leg fracture. So there's so many different types of these, but this is a displaced comminuted tibia-fibula fracture. You can see it here. This is one you guys probably see all the time. Trauma, motorcycle accidents, car accidents, falls. I'm sure you guys are seeing just tons of these. So the principles are all fairly similar if the fractures occur in the shaft. They are high risk for compartment syndrome because there is just so much vasculature here. It's a very small compartment overall. Most of the compartments are pretty small. This is a smaller area of the body, so there's not a lot of place for the swelling to go. So when the area swells, you can often compress the vasculature as well as the nerves in this area. Because the area is very superficial and your tibia sits very superficially, these are pretty commonly open because the tibia will pop off and then fracture pattern comes out. And if you see even any area that's open, that's it's an open fracture. Even if it's a small area, it's not bone sticking out. So that changes management, and make sure you're looking really carefully. Certain injuries of these can also injure the peroneal nerve or the fibular nerve and or artery, which come on this side with the fibula fracture, or the tibia and the tibial artery. So make sure you're checking pulses, and you want to check not only you want to check all your pulses in the lower extremity. You can use a Doppler if you need to. Make sure you're checking capillary refill. And you get your x-ray, you can consider doing immediate splinting. If there's any concern for vascular injury, a lot of times you will need to get a CTA of this. So they give contrast to see what the vasculature is like in the lower extremity. With these, they a lot of times will need an initial reduction in the emergency department. Sometimes if they're going to go to surgery right away, you may not always do the reduction, but sometimes they will, and that can reduce the patient's pain, decrease your risk of compartment syndrome and or vascular or nerve compromise, like we talked about. And then so get the splinted reduced, make sure that the extremity is elevated, and then their pain is controlled. And if it's an open fracture, you're always going to make sure you're cleaning it out, getting orthopedic surgery involved, and then usually giving antibiotics and then a tetanus. And the other last note about those is those are really commonly associated with DVTs in the long run. So if by chance you are just splinting and sending. So this is a knee dislocation. So it is distinct from a patella. We're not talking about patellar dislocations. Those are more minor. This is a dislocation of the knee joint. So the femur about the tibia and fibula. So these can be obvious, like in this patient, or they can be more occult, meaning they happened and then the patient is coming to you like, hey, I heard a click, and then it kind of clicked back, and they're coming to you afterwards. You get an x-ray. It look like it's out of place, but it maybe has been. These can be unstable, so you can often disrupt a lot of the ligaments. So you can disrupt the posterior cruciate ligament, the anterior cruciate ligament, both come back here. Also, your medial collateral ligament and your lateral collateral ligament can all be disrupted in this fracture pattern. So they're very unstable. A lot of times they will end up you'll need to get an MRI, not in the ER, but outpatient of these to see what the ligament injury is. Immediate reduction, like say you do see this in the emergency department, you get a fracture, you want to reduce it pretty quickly. These are associated with a high risk of vascular injury. So disrupting and injuring the popliteal artery that comes right back here. You see this comes back, and it can very frequently cause disruption or injury, complete tear of that popliteal artery. Even if somebody has a pulse, they can still have a disruption of that artery. There's been some studies, and especially in obese patients, that this artery gets damaged with this fracture pattern. It's one where in a lot, like basically all knee dislocations, you should get a CTA to see what the popliteal artery is. You can do arterial brachial index, so where you do measure blood pressure on the both upper extremities, both lower, compare the difference. There's calculation, you can find that. So you can do that and keep an eye on it, or you can just go ahead and get the CTA because you don't want to miss that. And then you would get, and if you do see a vascular injury, obviously you would talk to your vascular surgeons to address that. So upper leg, so here is a distal femur fracture. And again, we've all seen femur fractures all throughout the leg, but this is a distal femur fracture. Distal femur fractures usually require a ton of force. They can occur in motor vehicle accidents. When you hit the knee here, they can occur from falling directly onto the knee, or it's more often how they occur. These come with a high risk of vascular injury as well. Any femur fracture really does. And a vascular injury in this area can cause a high amount of blood loss. So even if it's internal, you could be bleeding into this space. And it's a big vessel. So you have to always worry when you see femur fractures and be doing constant pulse checks, skin checks, monitoring the patient's blood pressure, their compartments, making sure you're not missing these. These are same thing with this one. You can do the ABIs or just get a CTA of the leg. If if you can, a lot of times orthopedic surgeons, they will want CAT scans of these to make sure they're not missing coronal fractures and to really see the fracture pattern. This fracture can be extremely painful, so you oftentimes need a lot of pain medication in these patients. You can do a hematoma block here. You can use narcotic pain medications. Sometimes you can use muscle relaxers as well, because the muscles of the hamstring and the quadriceps are so strong, and they will spasm and cause this fracture to move. So you can add some muscle relaxer like a Valium or Ativan, something like that. Some people, they always just go to like pulling traction or putting these patients in traction devices, but it doesn't always show a huge benefit. It can help with pain control, but it can be also very difficult depending on the patient and how well they're tolerating things. So you can, for ease, just put them in a knee immobilizer. You can perform a fascia iliacus block, and I have a link for that on the next slide, and that can help as well. And then these all require orthopedic surgery consult. They usually need to be inpatient because you can't send them home. You can't go home until this fracture is fixed. So hip, this is one of probably the most common fracture I feel like I've seen, but this is an intertrochanteric fracture. So here's the greater trochanter, lesser trochanter, here's the femoral head and neck, and then here's the fracture. These are extremely common in elder people that fall onto their hip. They can be common in MVCs as well. So really common fracture pattern, but much more common in elder patients, especially if they have osteoporosis. The x-ray is negative, but your patient is unable to bear weight. You still should have a high suspicion for an intertrochanteric fracture, and you should consider getting a CAT scan or an MRI of the hip to rule that out. Because so many of these occur in elder patients that are in poor health, you don't want to be giving them a lot of narcotic pain medication. A great tool is a fascia iliacus block. So it's a block. You can do this with ultrasound. If you do a fascia iliacus block, sometimes you will cause decreased sensation because you're blocking the nerve. So it is good to consult your orthopedic surgeon or contact them before you perform this to make sure they're okay with this. They need to understand from our perspective that we're worried about the patient's overall well-being, and we don't want to keep giving them narcotic pain medication because it's not the best thing for them. And explain to them why you're doing it. And especially if you get good at doing it, they'll trust you. But sometimes they'll want to see the patient first so they can check the patient and make sure they have good sensation things before the procedure. And so good option. And so you'll be able to check this out. But again, it's like a 6-minute video. So I'm gonna let you watch it on your own and then consult them. They are gonna need inpatient. They can't bear weight. It's hard to sit down. They need pain control. Can't go home with this. So they are gonna need surgery, and they usually need this as an inpatient setting. And then I think this is the last one we have. So this is a hip dislocation. And we're really mostly going to study native hips, so not a hip replacement. So a hip replacements, they pop out all the time, and it's a little bit different. This is a native hip or somebody's regular hip dislocations. So this would require a high energy trauma. So motor vehicle accidents, you can see these with seizures, you can see these with a major fall, major pulling, but they do occur. 90% of hip dislocations are posterior. A lot of times, because of the force required for a hip dislocation, there's concern for fractures. So you can either get CAT scans before, if you can get it done really quickly, but a lot of times you want to reduce this and then get the CT after you've done the reduction of the dislocation. If there is associated fracture, you can still reduce it. You still should reduce it. But sometimes if you want, you can consult orthopedic surgery to help with the reduction because they can be more difficult if there's an associated fracture. With these, because the vessels will kind of overlie where this sits into the normal joint space. So you have vessels that kind of overlie here. When this pops out, those vessels can be stretched, which diminishes blood flow to the hip. So then you're not getting good blood flow to this area of the ball, and it can cause that hip can get avascular necrosis. So it can start to die. If that dies, then the hip and the joint itself will never go back to normal. And sometimes eventually these people end up needing hip replacements, or they'll get severe pain and arthritis in that area. So these, you want to minimize the length of time that it's dislocated to prevent the time that it's not getting good blood flow. So the reduction is here's I think these are some reduction techniques of the hip. Yep. And so I put in some hip reduction techniques. There's several. I can tell you for me, because I'm really small, like there's something called Captain Morgan. Does not work for me. I usually stand on the bed for these, and I have people help me stabilizing the pelvis, and I'll pull traction about the knee with the leg flexed. And then the patient's body flex. So there's some options here. So get good at one, and then you'll figure it out. So like I said, for a lot of those videos, when I send this link, you can watch them, and I would recommend it. So those are the fractures. And I told you it was a lot, and I knew until we went almost the full hour. And there's a lot of information, and kind of like I said in the email, if you guys have good fractures or specific cases, because this is one where there's just so many different fracture patterns, and it's great to just review them and see how other people manage them and their cases that they see. It can be really helpful to share and learn from things in this way. So yeah, any questions for me? Okay. Well, if there's no questions, you can always email them to me afterwards. And otherwise, I guess, yeah, have a good day. And then I'll send out the link. And next week, you guys will have the residents, and you guys can talk about, I think we talked about doing some with orthopedic surgery, doing some splinting, doing some procedures like arthrocentesis, and then focusing on pictures and looking at x-rays. And then when we move into derm, doing pictures of the rashes. All right. Well, if that's it, I'll see you guys. Yeah. Yeah. What? Oh, good. Okay. Okay, good. Well, I hope you guys got it. Yeah. I know. I know. Oh, absolutely. Yeah, and I mean, so the reality is sometimes a fracture is like painful and debilitating as it can be, it's lesser on the spectrum of emergencies you see. So it's like somebody has heart failure or difficulty breathing, you're going to see them first and prioritize them over the fracture. So, it's what it is. You got to like manage your time and manage what you can do.
Right, of course.
Yeah.
So we have spent a lot of specialists and surgeons will come at the same time, so they will
Yeah.
make the best for the patient.
Yeah, absolutely.
Right, truly.
Yeah,
So
for sure.
next week, there's two residents will talk about the nerve block or something like that. They have they want a mannequin and something like not mannequin but the sim lab, and
Yeah.
I want to practice there with the very long needle for nerve blocking.
Yeah, that's pretty awesome. Yeah, nerve blocks. So
Mhm.
there's videos in here, but yeah, nerve blocks are great. So
Right.
I'll also just like I'll send out this PowerPoint right now so that you guys can review any of those videos immediately if you want
Right.
to. Like the fascia iliacus block.
All right. All right.
Okay,
See ya.
guys.
Thank you. Thank you
Yeah,
so much, Claudia.
you're welcome. Bye guys.
Yeah, you're the best. Thanks.
Bye.
Bye.